Hello everyone, this is Dr. Ragib Shahriar, starting our weekly explainer videos on the most tough topics of the MRCS Part A. So today, without any delay, we will start our today's video explaining the hip fracture topic. This is one of the most important topics of orthopedics in MRCS Part A, and it seems that in everywhere there seems to come one or two questions on this topic. And the type of questions are usually they give a scenario in which a 60 to 70 years old female or male have some kind of accidents, they have some pains in their thigh or hip joints, and then they come to the hospital and there the diagnosis made on some kinds of variation of hip fracture, and then you have to select which is the best treatment modality for this gentleman. So without any delay, let's go to the topic. So usually we first of all we start with some kind of background. We have to understand the background to understand and to analyze the scenario given in the exam. So usually there are two kinds of patient who suffers from the hip fracture. One is the young patient, and in young patient the bone is very tough, so it needs a lot of energy to get the fracture done. And another kind of patient is the elderly patients who are predominantly female. Why the predominantly female? Because they suffer from the osteoporosis most often. Okay, so now to understand the main pathology of the hip fracture, we have to look at this photo. Okay, so what you can see from this photo? So actually this is the photo explaining the blood supply of the femur or the hip. What you can see from this photo, this is the artery which is mainly responsible for the blood supply of femur. This is the deep femoral artery. This is also called the profunda femoris artery, which is a branch of the common femoral artery. From this artery there comes two branches, medial and lateral circumflex femoral artery, and just look at the position of this artery. They are located along the neck of the femur. Okay, and what do they do next? They just go backwards from here to the top of the head. And so what is the problem with these kinds of blood supply? The problem is that if there are some fracture here around the neck, then this blood supply get disrupted, and eventually due to the lack of blood supply the head of the femur dies. Okay, so based on this theory, what can we assume? We have to assume that when there is any kind of scenario that states that there is a femur fracture, we have to first get to notice about the location of the fracture. If the fracture is in the neck, we have to take decision about the head of the femur. And if the fracture is below this line, okay, above this line, there is the blood supply which supplies the head. And if any kind of fracture happens below this line, you don't have to worry about the head at all. Okay, so that is the knowledge you have to gather from the anatomy here. So then about the presentation, eventually the patient comes with pain in the hip, and the leg or the lower limb seems to have shortened because the bone is fractured. The thigh is pulled upwards and it gets abducted and externally rotated because of the pull of the muscles. When the bone is intact, the muscles cannot pull the bone up or in any direction, and when the bone gets fractured, the largest of the muscles, which is the gluteus muscles has the most energy, so it pulls the fractured bone in its direction. So what is the function of the gluteus maximus muscle? It abducts and externally rotates the hip joint. So eventually, due to the action of the muscles, the thigh or the lower limb gets shortened, abducted, and externally rotated. Now we comes to the management. So what do you have to do to diagnose the hip fracture? So what we actually do is that we do an X-ray, and In some clinical cases, we do the X-ray of the pelvis to get the view of the both the hip joints, but the standard is to perform any hip X-ray. And now there's the problem with the hip X-ray. Sometimes, if the fracture is very minimal or the fracture is not displaced, sometimes the X-ray cannot diagnose the fracture. Then, what should we do? This is the problem when which comes again and again and again in MRCS Part A. Just look at this word, MRI. MRI is the gold standard of any kind of neck of the femur fracture. Why? We always just come to know that the CT can see the bone far better than the MRI, isn't it? The reason is that you have to just look back on your knowledge of the stroke. If you recall that, you can know that in kind of any kind of stroke, we do an CT scan at first, but there are some limitation of CT scan. What are the limitation? CT scan of the brain can only diagnose hemorrhagic stroke in the first 6 hours, because it cannot diagnose any kind of ischemic stroke, and it cannot visualize any ischemic changes. But MRI has a very superiority of diagnosis any kind of ischemia of any affected tissue. So just using those properties of MRI, we can use MRI to diagnose ischemia of the head of the femur. So just you have to remember this word. The gold standard investigation is MRI. But there is a catch. If the MRI is not available within the 24 hours, or the patient may be claustrophobic, so in that kind of situation the CT scan is appropriate. Okay, now comes the classification, which is very important in decision making. So try to remember what I have told you so far. Previously I have told you that you have to remember this red dangerous line. If anything happens above this line, there will be damage to these life-saving blood vessels to the head, and you have to worry about the head. And if anything happens below this line, you don't have to get tensed about anything about the health of the head. Just remember it and you are good to go. So now, before taking any kind of decision, you have to first understand that if the fracture is extracapsular or intercapsular, because of this line. Okay, the capsule of the hip joint is attached around here. So if the fracture is intracapsular, it means that the fracture is above this line and you have to worry about the head. If the fracture is extracapsular, it means that the fracture is below this line and you don't have to worry about the head. So the first most important classification is the fracture is intracapsular or extracapsular. Got it? Now get deep into the intracapsular. The intracapsular fracture is again divided by a very important classification, which is called the Garden classification. It is of 4 types. That is, here there is incomplete fracture. The fracture starts here but doesn't reach up to there, so it is incomplete. The number 2 is the fracture is complete, but the fracture fragments, this one or this one, doesn't move. Okay, if it starts to move, so there are some kind of displacement, it gets number 3, and if just it get fully displaced, it is termed as Garden stage 4 fracture. Why this is important? Because any kind of fracture here, this is dangerous. Which is more dangerous? If there is any kind of movement around the fracture line, because there is fracture, there is a limited chance the blood vessels are not damaged. But in these 2 cases, obviously there is no chance of preserving the life-saving blood vessels to the head. So in Garden 1 and 2 fracture, you can just get done by stabilizing the head and the neck by putting a pin here. Okay, put a pin here, it will not move, the head will survive, the blood vessels will continue to move blood to the head, and here the fracture fragment moved 1 to 2 centimeter, and here the fracture fragment moved totally towards the opposite direction. So the blood vessels are not here to provide the life-saving blood to the head. It is, we have to assume in number 3 and 4 kind of fracture the head is already dead. So we have to worry about how to replace this life-saving head. Okay, so there are three things you can two things actually you can do here. You can only replace the head, which is called hemiarthroplasty, and you can replace both the head and also the cavity, the acetabulum, where the head resides, which in that case the surgery will be called total hip replacement. So when to do which one? If you only replace the head and if you keep the acetabulum, what will happen? The head is prosthesis, it is made of metal or ceramic, but the cavity here, it is bone, the natural bone. So the more hard one or the artificial tissue here, artificial head here will react with this acetabulum. It will erode the acetabulum, and the patient will come to you 1 or 2 years later with the complaint of osteoarthritis, which will be not good for the reputation of the surgeon. So in the patients who have the chance of more mobility, who have more years to live, in those cases you have to replace both the joints and also the cavity to prevent the osteoarthritis. So in young patients and old patients but who are fully independent and mobile, you have to give them total hip replacement. And in the case of the patient who are already a lot old and they have some limited mobility and they don't move so much, so they don't have the chance of coming to you again with the complaints of osteoarthritis. So you can just get away with doing half of the operation, which is called hemiarthroplasty. Okay, so if you have understood this flowchart is very easy to you already. Just look at them. Intercapsular fracture, if it is undisplaced, you can do pinning by internal fixation, both in young or the elderly. Undisplaced mean you just keep a pin and fix it internally and you are done with it. But if the fracture is displaced in young patient and the patient who are very much mobile, who lead an independent life, you have to provide them with total hip replacement, because if you do half of the surgery, the patient will again come to you some years later with pain due to osteoarthritis. So to prevent that, you have to replace every part. And if there is any displaced fracture in elderly patient, but the patient has a lot of comorbidities, he will not tolerate a very long period of anesthesia, and also because of less mobility, the patient will not have there is less chance of getting an osteoarthritis because his or her joint will not move too much. Okay, so then you will get over with half the surgery. You will only replace the head of the femur, and the surgery will be called hemiarthroplasty. Remember, hemi means half. Okay, so we are done with the intracapsular fracture. Now we start with the extracapsular fracture. So capsular fracture means the fracture is below the line I have described you so far. Okay, now again we come to the picture here. So the fracture is below this line. What happens below this line? There can be some variation of the fracture. The fracture can be along the line connecting the two trochanters, the greater trochanter and the lesser trochanter. Here there may be fracture running along the line, which will be called intertrochanteric fracture. Again, this intertrochanteric fracture can also may happen in a reciprocal direction like this. If the fracture happens along this line, it will be called reverse trochanteric fracture. And lastly, there may be some simple fracture around here. Okay, So there are three options for each of them. If there is a fracture along the intertrochanteric line, there will be a special instrument which is called dynamic hip screw. It looks like this. It stays there. It is called dynamic because it moves with the movement of the hip joint, and it due to its micromotion, it helps in the regeneration of the bone. And if the last two ones, the reverse trochanteric and the subtrochanteric fracture, the fracture is not in the neck, the fracture is already coming to encroach up to the shaft of the femur, isn't it? So what we use in the fracture affecting the shaft of any long bone? We use IM nail. So in these two kind of fracture, the reverse trochanteric and the subtrochanteric fracture, the option is IM nail. So again, to recap, there is hip fracture. You have to first determine it is intracapsular, extracapsular. Intracapsular means it happened above this line. If above this line, you have to determine the Garden classification. If the Garden classification is 1 and 2, you are done with just putting a pin, putting an internal fixation there. If the fracture fragment are already displaced, you have to replace the femur head. And there comes two options, only to replace the head and also to replace the socket. In young and mobile old patient, you have to replace both, which is called total hip replacement. In old patients with multiple comorbidities and less mobility, you will get away with only replacing the head, which is called hemiarthroplasty. Now, if the fracture is extracapsular, it will happen below this line or along this line. If this is happening along the line connecting the two trochanters, it is called intertrochanteric, and you have to put a dynamic hip screw there. If this is along this line, the reciprocal to the previous line, this is called reverse trochanteric. And if the fracture happens along this line, it is called the subtrochanteric. In these last two cases, we will just get away with putting an IM nail along the shaft of the femur. So this is all about the hip fracture. I hope these two algorithms which are described in the NICE guideline of the hip fracture is totally easy to all of you. Just again look at this red line I have just written here. You can pause your video at this point. You can read through these red lines here, and hopefully you will understand all of this. So lastly, I tried to keep the video within the 5 minutes, but it went into probably 15 minutes. But I hope the 15 minutes have been spent very well, and I have been successful to make you understand about the management and the pathology and the anatomy of hip fracture. Okay, you can pause here.